Our mission is to provide optimal health services in support of our nation's military mission. Now, that is primarily soldiers, sailors, airmen, Marines, and Coast Guardsmen, and their families and the retirees. About 2/3 of those who served and are now retired are in our system, not in the VA system, so we have a large system. We have these overlapping spheres of activity: casualty care and humanitarian assistance. We've lumped them because they're both overseas. We strive to have a fit, healthy, and protected force, and healthy individuals, families, and communities. In the middle, we have an engine of research, education, and training, which produces the next increments in knowledge and in personnel. We have a problem in the Defense Department in that we have to lead a system of systems, only some of which are command and control. You cannot command a wife or mom to get care at Walter Reed or Bethesda or Portsmouth or Balboa if she wants to get care for the family downtown from one of the TRICARE contracted doctors. That's choice. Choice is critical for competition. Competition is critical for excellence. So we don't exactly have a command and control environment in military health care as we do in other aspects of military leadership. Secretary Togo West, who used to be Army Secretary and then VA Secretary, pointed out that, yes, we have to put the mission first in the military, and there are times, but not many, when that may disadvantage a given soldier, sailor, airman, or Marine. Although we think that here's an example that was cited. In World War II, at the beginning of the war, if you had a temperature of 99 degrees with malaria, you got pulled off. By the time they'd gotten to some of those that next chain of islands, there weren't as many sailors and Marines. You didn't get pulled out of the fight unless your temperature was 103 from malaria. They needed everybody, that could shoot to be shooting. So in that case, each finger strengthens the hand, and the hand strengthens each finger. But they were throwing people into the fight with a high fever from malaria. So we have this issue that you don't have in the civilian world, except on a football team, baseball team, or in industrial medicine. The guys and gals who served 20 and 25 years ago, 30 years ago, for a much lower salary and far inferior benefits, many of them, on a draftee basis, certainly feel that they got a promise, explicit or implicit, that they would get care for life. And many of them will say that this promise is not being kept. You can refer them to the fine print, and they don't appreciate that. So we have to, if there's a way that we can do more for them in this valley between active duty service or reserve service. As a reservist, I know exactly the issue. And before you get TRICARE for Life, we would like to hear about that. That is it's a weak spot, and some assistance in this area would be appreciated. In the prevention aspects, we are pleased that we exceed the civilian sector now in colonoscopy and pneumonia vaccine and influenza. But influenza, we had to order people to take it. And pneumonia vaccine, the Army is paying people cash to take the pneumonia vaccine because there was resistance to it. So we're seeing some flexibility and some innovation. This is the kind of thing we call pay for prevention, which we hope to get in a redesigned system. Once the incentives are aligned and the metrics are aligned, the outcome measures, as Dr. Walensky mentioned, that in fact people could go back and forth between private care and military treatment facility care with their portable records,
with a clear sense that they're the owner of their care, that they have some responsibility for their care, that they have choices in their care. This kind of opportunity is possible in the system where 97% of our enlisted have a high school degree or equivalent degree now. All of our people are computer literate. They have a great sense of responsibility. And so I believe we can be in the lead in patient accountability, doctor accountability, nurse accountability, alignment of incentives. And so, but your guidance on this would accelerate this.